Good afternoon, everyone. Thank you for attending this session of the Kansas City Echo Society meeting. I'm Timothy Bieber. I am the medical director of echocardiography at the University of Kansas Health System. And I wanted to share with you today some insights into transcatheter clipping. I think this becomes important because, as with most structural heart procedures, we haven't thought a lot about the tricuspid valve in detail, which is what focusing on a procedure like this does. So it's important to categorize and understand a little bit more about the tricuspid as well as how the procedures go, so that if you're referring patients or you're trying to image the patient, you can have a better understanding of the pre-imaging, whether it be transthoracic, transesophageal, or imaging during the procedure. I have no disclosures at this time. So just an overview of what we're going to be talking about today. Why are we talking about the tricuspid regurgitation? The anatomy of the tricuspid valve, the transthoracic grading of tricuspid regurgitation, which is something that has been difficult in the past, and then the TE assessment of the tricuspid valve, or what I call the tryout, and then some of the intraprocedural imaging and guidance of the tricuspid edge-to-edge repair, or what I deem the show. So the reason we're talking about this is the prognosis of untreated tricuspid regurgitation remains poor, and patients end up even receiving a lifetime of medical therapy, and this proceeds to intractable right heart failure and organ dysfunction. Despite the current guidelines favoring early tricuspid valve repair in patients with tricuspid annular dilatation undergoing left-sided cardiac surgery, even if the TR is mild, there's some reluctance to perform tricuspid surgery, and it stems from increased hospital mortality, particularly following left-sided heart valve surgery. Of note, the isolated tricuspid valve surgery remains pretty rare as a procedure to do, and the operative mortality rates are pretty high, which also adds to the reticence. So that's what led to a lot of attempts to try to figure out a structural heart approach to the tricuspid valve. And as with the mitral, the edge-to-edge repair had to be translated to the other side. So to that point, we have been involved in the Triluminate trial, which is one particular vendor's clip that has year-out data. And as you can see, looking at the data that's presented so far, there's been a tricuspid regurgitation reduction of at least one grade that were achieved in 87% of people out 1 year. The proportion of subjects with moderate or TR went from a baseline of 4% to 54% at 30 days and 64% at 1 year. And we look at also parameters of the right heart, TAPSE, RA volumes, and diastolic dimensions, and those showed improvement as well. What we're trying to accomplish is a clinical benefit to these patients, and the trial data thus far showed an improvement in New York Heart Association functional class, as well as data of decreased hospitalization from heart failure and death. So it's been positive, and I think that as soon as these devices are FDA approved, there's going to be a lot of referrals for this procedure, and that means a lot more imaging for us and trying to figure out patients that would benefit from the therapy. So just a little bit about tricuspid valve anatomy. Ironically, the tricuspid valve is not always tricuspid. There's a significant heterogeneity of leaflet number, where 3 leaflets is still the dominant 54% of patients, but about 39% of patients have 4 leaflets. A small percentage have a bicuspid or a 2 leaflet valve, and then there's also a small portion, about 2%, that can have 5 leaflets. A lot of this is scalloping and separation of the posterior leaflet. Luckily, since the majority of the patients have a 3 or 4 leaflet valve, early work suggests that clinical outcomes of edge-to-edge repair between 3 and 4 leaflet configurations are similar. So this is just a pictorial from transthoracic from the European guidelines, just looking at some of our typical views. On the top left is the apical four-chamber, and then the two pictures to the right of that are an aortic valve short axis or RV inflow outflow view. The bottom pictures are the RV inflow view from the parasternals, and this is just demonstrating that there's some definite ambiguity as to which leaflets you're seeing in each one of these views. So we try and given the information from the previous slide about the number of leaflets that the valve can have, it's sometimes difficult to actually obtain morphology from a transthoracic. That being said, there are times where you can get, if the patient has very good subcostal images, a better idea of the morphology in the short axis in the subcostal views, but this is not every patient. So, but you can definitely see where you can categorize them as the far left A panel, which is a bicuspid valve, the middle panel, a trileaflet, or the far right panel, a quadricuspid valve. And similarly, the 3D images mirroring that at the bottom of the screen. So now I'm going to move on to talk a little bit about TE, which I deem the tryout. Part of the reason I deem that this is because imaging is so important in these structural heart procedures. And as we proceeded from TAVR to MitraClip and mitral procedures to the tricuspid side now, is that this TE for qualification and to assess the pathology and the severity is really the tryout for the procedure, because a lot of these procedures can't be done if there's not certain imaging that's available during the procedure to be able to look at the catheters and the clip orientations and other things, which I'm going to go over. So it's really important that the person that's going in to do this pre-assessment sees that as a tryout, even if you're not the one that's going to be in the procedure helping the interventionalists and the surgeons perform the procedure. It's important for you to show what can be imaged in the patient. So that's what we're going to talk about a little bit. So why is the tricuspid valve so hard to image? First of all, the tricuspid valve leaflets are much thinner than the mitral leaflets with greater anatomic variability. The tricuspid valve is the most anterior, which is further from the esophagus to the four cardiac valves. And the path of the esophagus does not allow en face imaging and requires the use of lateral resolution, which we know is actually more poor than axial resolution. So this is just a diagram out on the top left out of the transesophageal guideline, which I think is important to understand. We're talking the same language about flexion to left and right, antiflex, retroflex, and then rotation of the probe. So we typically think about basically four positions for the TE probe here: upper esophageal, mid esophageal, transgastric, and deep gastric. And as you can see that on the diagrams from our classic views, which would be a four-chamber, our mid-esophageal sort of 60-90 degree views, that you see different portions of the leaflets in 2D. And so it's important to understand what you're seeing, just like with the mitral valve, when you're in a certain position in the esophagus. So the gastric views are essential for this procedure. You can't do gastric views because you have 3D en face like you do with the mitral valve. So your gastric short axis views, whether you get them from a baseline 0 degree view or 0 to 60 degree view with rotation of the probe, or you have a long axis view that you X-plane off of, it's tremendously important. So the other thing that has come into discussion about this, and Becky Hahn's really the one I've heard talk about it, but that's frequently used is this deep or lower esophageal view that's between the mid-esophageal and the transgastric. It's not necessarily always obtainable, but it gives you a different perspective of being able to see, because sometimes when you push towards that view, which is where the opening of the coronary sinus is, you are more perpendicular to that tricuspid valve. You can see it better and are able to categorize and see the leaflets. So it's so important because you're going to be guiding the clip as well as having to see grasping views. And once the system enters that right atrium, you're going to get shadowing of that valve, and you have to be very creative. This is part of the reason I love structural TEs, because it brings out creativity. You can't just follow a plan. You have to look at the patient, see what images they have, and then work around what they give you to try to be able to help the surgeon and the interventionalist see. So I think that's very important. So this is just an example of showing, first, this is a deep esophageal view, but a mid or a deep esophageal, multiple different angles. I think importantly, for me, I look basically at the tricuspid, just like I used to look at the mitral, which is basically every 30 degrees. So 0, 30, 60, 90, about 120, and about 150. It's important to be able to show what views you can see. And it's also, you're trying to categorize the severity of the tricuspid regurgitation, see where any leaflet gaps are, which you can see in the upper panel pictures the best, I think, at 30 and 60 degrees, yeah, but even in 90, and then as you come around to 120, that there's a significant leaflet gap here. And that's so helpful in being able to decide later on where you're going to be able to see once the system's in there. So again, you can see in the top left-hand screen how bright the tricuspid valve is to what you normally see it in a normal mid-esophageal view, because you're not having the image through the aortic valve, annulus, or any part of the annulus there, because it's gone, because you're pushed all the way in and really have the coronary sinus there. So that leads to a lot of good multiplanar reconstruction views, and also gets you a lot of times around the system that's in the right atrium when you can't see. So just one of the other critical concepts or views is this RV inflow outflow view, which usually obtained from 60 to 90 degrees. So the bottom left-hand screen is a 3D picture showing that view. And then similar to the top right is a biplane image of that view showing an plane through the center of the valve. And you can see how you can see the leaflets on the other side. And we use this a lot when we're doing grasping views and other things, but it's very important to be able to categorize sort of the leaflets. So in this view, you have your aortic valve as your anterior marker, which usually marks the anterior leaflet to the right, and then the posterior leaflets to the left. And then as you can see in the 3D, there is the septal leaflets in the background. So when you're explaning through this, you are explaining through and being able to, on the right, see the certain leaflets that you're looking at, whether you're on the left or the right hand of the screen, for your 2D short axis view in your biplane. So just to drive this home, because this is what you're trying to prove before you go to the room, is we are trying to look for being able to see each portion of this different set of leaflets. So this is, you're sequentially going across the leaflets in the septal posterior commissure that's to the far left, and then you bring the septal posterior to the leaflet tips, which you can see. So the red line there is the septal posterior commissure. As I come to the right to the septal leaflet tip, I'm seeing septal posterior at the tips. As I come over to the septal anterior leaflet tip, I'm seeing that on the right, the septal anterior, and you can see the gap and know where it is better. And then the far right, as I get to that annular portion of the anterior leaflet, so I'm seeing on the right, I'm seeing anterior, septal and anterior leaflets. And so being able to identify which leaflets are where they're prolapsing, where the gaps are, is very important, as well as distinguishing how you can show them during a grasp or assessment during the procedure is important. So the lower hand panel is really just seeing the regurgitant views as well, which is important because it shows you sort of where the dominant jet comes from. And as we'll see later, when you have other issues, pacemaker wires and other things. So the gastric short axis views, as you can see up there, I put in big bold letters, is mandatory. So just looking through this set of images, the top left is just past the coronary sinus before you actually push all the way into the stomach, is this what I call Becky Hahn RV inflow view, which has the right atrium to the left, inflowing through the tricuspid valve to the right. So that's a very useful view. You can get severity information there, as well as you can see the right-hand view. I can X-plane through that and get a gastric short axis if I need to, if I don't have better images further in the stomach. So the bottom left-hand screen is the gastric short axis view that you optimally want to get. You don't want to really get that at 0. You want to get it somewhere between 30 and 60 degrees, because as you rotate at the mouth, you want to be able to go above and below the valve, because you're going to have to use that to be able to see clips, as you can see in the right-hand bottom screen, where I have a gastric short axis on the left biplane, and I'm X-planing through the clip to try to look at where it's being grasped. So as well, a lot of times, the difficulty when the right atrium is football field size, and you're trying to look for severity, and you have issues with shadowing with the aortic annulus and other things in the mid-esophageal views, you should try to use the gastric views to get all the information you can, if you have good views there, which they have to have for the procedure. So if there's a deep gastric view, you can a lot of times see the leaflets well. You might have to see grasping there in the future. The short axis views, as you can see, the 30 to 60 degree label that I have up there is important. And then I always will go around to 90, 120, and 150 to look, as you can see in these pictures, which we're going to talk about, pacemaker wires, but also see severity, because a lot of times when you're imaging the tricuspid valve down here in long axis views, you actually get a little bit more parallel to flow, and sometimes you can see the severity better. So, but this again is a tryout. You need to figure out all the images you can get that your colleague or yourself are going to need to get in the room. So coaptation gaps are important, as we saw with mitral clip on the other side, understanding how big our gaps are, because once you get beyond about 6 millimeters, so you can see in the left-hand pictures at 0 degrees and almost 150, how well you can see the gaps, and you can measure those. So once you get about beyond 6 millimeters, it's hard. It's important to understand when you're doing a clipping procedure that, yes, you're clipping the leaflets together, and that's creating coaptation, but what's also you're doing is pulling the annulus closer together, so the remaining parts of the leaflets come into closer proximity and have the opportunity to coapt. So that is what you're actually doing an annuloplasty, as well as pulling leaflets and coapting next to where the clip is. So when you're looking at these gaps, this is where learning new software and the multiplanar reconstruction views come into play. So as a lot of us have seen in the past when we're performing TEs, if you go to a 90-degree bicaval view, like in the top left-hand picture, you can just hit a live 3D on and actually see the tricuspid valve in short axis very well. And that doesn't always work, but sometimes it gives you a good picture you can rotate. So what's been great, at least for the systems that we use, which our system is particularly advocate, but most systems have this more live multi-planar reconstruction views. Prior, this was 3DQ on the Epic or the Philips system, which you had to do offline, but now you can do live reconstruction where you can align your planes to the tricuspid valve, as you can see on the top right. So that's a optimized view there, where I've created a region of interest and actually shown the plane to go straight through the RV and the region of interest I want to see. So on the bottom pictures, I have a short axis of the tricuspid valve in 2D on the left, and then on the right, a 3D image of that tricuspid valve. And so the bottom left-hand picture is just a large view of that 3D picture, showing how well you can see the morphology of the valve, the posterior septal, anterior leaflet, and that coaptation sort of gap there. And then within that same live view, you can choose how you view it. So if you have one image that you want to view large, you can have 3 thumbnails on the left, and then have whatever image you want on the right out of the 4 you have. So you can sequentially choose these, but I wanted to measure the gap area in 3D, particularly on this one. So you can see I was able to freeze the valve at its closing point and measure a gap area. So we talked a little bit about 3D vena contracta area / EROA. And as you can see, similarly from this picture, that you also have a similar process that you go through. So on the top left is a multi-view MPR picture with the 3 different planes and a 3D on the bottom. So I started with a region of interest, and then changed to the 3 view where I could see the valve in 3D on the right and the 3 thumbnails. But then I was able to freeze it and then make my region of interest just the vena contracta area along the line, and then able to sequentially go through the 2D images to make sure on the left that I was cutting the vena contracta optimally, seeing the vena contracta in the 3D and the 2D. And then as you can see, the leaflets labeled and where that 3D vena contracta area is, I could measure on that 2D image the area that exists there to come up with what you can see is a very large area for this patient that has torrential tricuspid regurgitation. So it's very important for the sonographers to help their physicians, but also because I think this is going to be coming into the transthoracic realm, to be able to learn how to use the software, and the physicians have to understand it so they can make the best measurements. But it's very useful having these live multiplanar reconstruction views on these wonderful new machines that the vendors continue to improve. So pacer wires, being in this trial has been an adventure. I'm going to show you through a few of these. As we witness in the reading room every day before this ever came up about fixing the tricuspid valve, is we can see pacer wires very well. And with the advent of basically the EP, a lot of times placing for more native conduction, putting the pacing lead within the septum has created a lot more trapping of especially the septal leaflet, but other leaflets can happen as well. And then as the RV dilates, the lead becomes more straight, and it becomes a bigger problem. So in this particular example, in the top left, you can see the pacer wire. That's a 150-degree view. It's sort of a reverse 4-chamber down to the coronary sinus level, which you can see my arrows in the coronary sinus. It's humongous. So on the right, you can see the pacer wire in short axis by the point. That's the top right. And then you can see in the bottom left that the top right that the jet actually originates at the pacer wire, and the pacer wire is impinging on that septal leaflet. So in the bottom pictures, I use my multiplanar reconstruction to get on get all of my regions on that pacer wire, so I could identify it in 2D at the bottom left of that multiplanar reconstruction, which you can see as a bright dot. And then you can also see it from the 3D picture down there is holding the septal leaflet. So this is another view posteriorly where you can see the pacer wire in the top left in the gastric short axis. 123-degree gastric long axis view where you can see the pacer wire lengthen out with color showing the regurgitant jet flow is coming around the pacer wire. And then the bottom right is an X-plane picture showing that similarly that as the pacemaker wire pops in, the regurgitant jet's coming right around it. And then the 3D image on the bottom left, which I was able to do from the deep gastric view of a multiplanar reconstruction to show that pacemaker wires just down and to the right of that P, showing you the posterior leaflet and how it's really holding the posterior leaflet up against there and creating that problem. So it's very important for the people performing these TEs to differentiate this, because as you can imagine, pacemaker wires, you can't overcome pacer-induced tricuspid regurgitation with a clip. So that just doesn't really work. So I thought this was a good example too. So you can clearly see a biplane view from my RV inflow out view on the top left, showing a pacer wire that appears to be central. So what's important is to prove, where the jet's coming from and how centralized the wire is. So on the bottom left, in a long axis 150-degree view of the stomach, I can see I'm perpendicular to the pacer wire. I can see the length of it. I can see it coming through the valve, but more importantly, when I turn the color on, I can see the jet that it does not originate. And so to take that further forward, on the right 3D reconstruction views, you can see the posterior septal anterior leaflet, and you can see the lead from the white arrow is pretty centralized. And then a step further with a multiplanar reconstruction with all views on the bottom, you can see that. And it has some interaction with the leaflets, but it's mostly at the mid-coaptation point. So this is a patient that you potentially could clip, posterior septal, anterior septal, and improve the TR and just keep the patient wire centralized. So TE clipping day is the show. It's basically you did all this pre-work to show that this could be done. You understand the issues, whether there's gaps or pacer wires, and now you got to go in there and you got to, once the system's in the right atrium, you got to make sure that you know how you can get around it and do that. So these, as we said, these biplane pictures are very important. So the top set of views on the left, the biplane RV inflow outflow view of the actual clip with near the leaflets, and then the gastric short axis, you're constantly going between the mid-esophagus and the gastric short axis to show the clip orientation, which you can see on the right-hand screen is in that short axis picture, the clip is oriented perpendicular to that anterior and septal leaflet. So, and then you can see the leaflets well, that they were grabbed on the left-hand top picture. And then once they close the clip down, so the biplane on the bottom left-hand picture, you can see have leaflet insertion on both sides of the clip. And then the leaflet insertion on the gastric short axis shows you have a good grasp at those two leaflets. So these gastric pictures are being able to do these 3D reconstructions. If you can't see, once the system becomes more complex, the more clips you use. So the clips are always placed anterior septal to posterior septal, because once you put a posterior septal clip, as you can see from the top right-hand screen, you get a lot of shadowing and you can't see the anterior septal as well, but you can see both clips in these views. The bottom left-hand view shows a multiplanar reconstruction where you see the two long axis views. We're using the advantages of being able to slice straight through the clips on the two long axis views. And then in the short axis, you have a nice gastric looking short axis on the bottom left image of that multiplanar reconstruction. You can see both clips, one in the anterior septal, one in the posterior septal, that has good leaflet grasp. And then the 3D as well to the right, which is just a 3D of the gastric short axis, where you can see the laser lines are through those clips and there's good grasp and pulling the leaflets back in. So residual tricuspid regurgitation, we talked about the challenges earlier on to look after the clips are placed. I think, the challenges from transthoracic are more a lot because of the shadowing, but they still exist by TE. So you really have to do your due diligence to be able to look around as much as you can. This is a series from 30, 60, 90, 120, 150, looking at residual TR. And the top right-hand picture there shows a color compare in the 90 degrees, but that's in the gastric view. And as you can see, this is why it's important to understand and being able to have multiple imaging planes with looking at the tricuspid valve, because you can see the severity of residual TR the best in that 90-degree view in the gastric than you could in the mid-esophageal view at multiple views. So that's very important. And then, of course, we're always looking for gradients, just like we do on the mitral, to make sure we didn't cause tricuspid stenosis. But the tricuspid annulus is so large an area that it's very rare to have a significant tricuspid gradient once we're doing this. So the take homes from the TE is patient eligibility is highly dependent on image quality. The mid and deep esophageal, as well as the gastric pictures, are a must to be able to help guide the procedure. The pre-procedure tryout TE is essential for giving that information about physiology, clippability, and it sets the stage for candidacy when the surgeon and interventionalists are setting expectations for the patient during the consultation that they're having with them before they go to the procedure. So just from an acknowledgement standpoint, I can't do what I do without all of the wonderful people, sonographers, nurses, and everyone that work in my echo lab. This is just a board of their pictures that we have in our echo lab. I really appreciate all of their hard work and their willingness to learn new things, which is essential in a high-performing echo lab. So thank everybody so much.